Well, welcome everyone. It is, if you hadn't noticed, September. Schools are open. My commute was long this morning, 38 minutes in fact, according to the clock on my car. So we're back at it, and with the start of the new academic year begins our academic year 1920 Grand Round series. These will happen at 8 a.m. for September, October, and November. Beginning in December, and for the next 3 months, we will shift to noon before jumping back to 8 a.m. Just to remind you of the house rules, please silence your pagers and cell phones at this and every future Grand Rounds through the course of the year. If you can't make it in person, be sure to join us in WebEx. It's available on WebEx. I'm sure we have a robust online audience right now. And finally, we are encouraging all our speakers to leave time for questions. So when you ask a question, please, out of courtesy to the rest of the audience, wait for the microphone. Courtesy to the people online, rather, wait for the microphone. And please tell us who you are and where you were. We're trying to build a sense of community and family here, so the more we know each other, the better. Now, to introduce the first speaker of this year, we have Dr. Joelle Simpson from the Division of Emergency Medicine. Joelle.
Thank you all. I'm very excited to welcome you to the first Grand Rounds, and in particular because this is Disaster Preparedness Awareness Month of September. We wanted to sort of launch the Grand Round season with talking about an issue that's become more and more prominent across the country and certainly here at Children's National, which is being ready for disasters, particularly the disasters that impact our kids. So it's my pleasure to introduce Dr. Mark Cicero. He is a colleague in pediatric emergency medicine as well, and I've worked with him a fair amount in various committees on a national level in both disaster preparedness and emergency medical services or pre-hospital care. Dr. Cicero comes from us as an associate professor of pediatrics and emergency medicine from the Yale School of Medicine. He is the director of their pediatric disaster preparedness program and has been active in a lot of research around disaster preparedness and emergency medical services. He is the principal investigator for the Pediatric Research in Disaster Education Network and has also been funded by the Emergency Medical Services for Children program, which is a federal program that seeks to improve the care of kids across the emergency spectrum. So with that being said, Dr. Cicero, welcome to the mic.
Good morning, everybody. Thank you so much for the invitation to join you all today. Thank you for the introduction, Joelle. It's really an honor to be with you and to kick off this year's Grand Round season. Of course, we planned for this Grand Round some months ago. One thing that is sadly true is there will be some kind of disaster, right? The timeliness, the fact that there's a large hurricane threatening the southeastern coast of our country, and it just recently wreaked havoc on the Bahamas, could have been maybe predicted that something would happen, but it's mere timeliness that this talk coincides with what's happening right now. So I have no commercial disclosures, and I thank all of you as taxpayers and residents of Greater DC for funding our work over the years for the PRIDE Network. The next slide, the objective slide, is very much written in the language of objective and continuing and ongoing medical education. I'm going to unpack these words. So we're going to explore the evidence for current disaster triage systems and limitations of triage science. What I'm going to do is present some of the work that's been done in the U.S. and a little bit of what's been done in other nations regarding triage science and show where the large holes in the repertoire are. There's a lot still to be learned about triage. When I talk about triage, I'm talking about that initial application of order to a chaotic situation in the field. It's not a nurse or a tech or a physician most often who does that initial triage. It's an EMS provider, it's a paramedic, it's an EMT, it's a firefighter who's doing the initial triage, who's the first person from the medical structure who begins to take care of patients and make some decisions. Next, synthesize means for initial and subsequent disaster triage training for a range of healthcare professionals. quo. A range of healthcare professionals are represented right here today, across the career spectrum and across the range from nurses to, are there any allied health professionals in the room? Any speech language pathologists, PTs, others? I know that there are a lot of physicians in the room, a lot of trainees. Can I just get a hand up from some of the medical students who are in the room? Okay, great. So we have the range, and when we do this kind of training, when we do this kind of didactic training, it's like an old-timey one-room schoolhouse where there's a need to address everyone's learning needs. What's different about disaster medicine is even those who have a lot of experience in healthcare often don't have a whole lot of experience in disaster response. So we're going to take a look at the means for doing disaster training on an ongoing basis and an initial basis. And if you're an educator out there in the audience, even if you are unlikely to respond to a disaster, which these days few of us are unlikely to respond to a disaster, there'll be some pearls in there that may be helpful in thinking about how to craft a curriculum or an educational intervention. And finally, we're going to look at the vulnerabilities of children. We are all potentially vulnerable to disasters. We'll talk about disasters in just a second or two, but children even more so. We'll take a look at those vulnerabilities before moving into questions. So, if we use a definition of a disaster as an event that overwhelms the available healthcare resources, first, we'll take a look at what's the same. Actually, we'll take a look at what's different. Then we'll take a look at what's the same about disasters. So disasters may be sudden and unexpected. Some examples are up there on the slide. In a sudden disaster, generally, everyone who is going to be ill or injured as a result of the disaster becomes ill or injured at the same time. Here are some examples. Of course, we are having more weather events in the country, and if we define a mass shooting as an event where 4 or more people are injured or killed in that event, this map represents all the locations of mass shootings in the United States this calendar year. We are having, by that definition, 1.2 mass shootings in the United States per day. Now, issues of mass shooting, how to prevent mass shooting and the like are something I would be happy to talk about at a different time. It's a little beyond the scope of it. But I use mass shootings as an example of a sudden event, a sudden disaster that can potentially overwhelm healthcare resources. Disasters can be sudden or they can be delayed. There is no better example at this moment than Hurricane Dorian, an example of an anticipation period. People along the east coast of the United States, certainly in Florida, certainly in the Carolinas and in Georgia, doing what I do, I'm already thinking about, will this storm maintain enough strength and integrity to come up and cause some winds and flooding in coastal Connecticut? And I'm sure you're starting to wonder, if there'll be an impact in greater DC from this storm. When there's a delayed event, there's more of a chance to bring healthcare resources to bear and to bring the healthcare infrastructure to play to respond. However, people may be ill or injured early in an event like a hurricane, or we may have an event like a hurricane where we have patients who months or years later are still suffering mental health consequences of a disaster, and patients may present far later after. There's some other examples, including pandemic influenza on the slide. So again, what disasters have in common is they have the potential to overwhelm healthcare resources. They may vary in scale and their duration, and then this is important, the pre-existing resources in the site. So if we imagine an event where there is a minivan full of unrestrained children that rolls over on an interstate, right? Here in DC, where there is a robust EMS infrastructure, where there is a world-class children's hospital and a number of other hospitals that are prepared to manage trauma, that event will be dealt with differently than if it happens in, say, far western Maryland, or if it happens in rural Vermont. The resources that are present help us define whether this is a disaster or whether it isn't, and also, more importantly, impact how patients, how families will fare after the disaster occurs. Children tend to be disproportionately harmed Children are more vulnerable, they have less agency, they're less able to flee a disaster, and they're prone to things like family separation. Also, children, by their lot in life, tend to be more likely to live in poverty and have fewer resources to have a robust response, a resilient response to disasters. And we'll talk about children's vulnerability in some detail at the end of the talk. In any disaster, there's a balance. There's a balance between the needs on the left-hand side of the screen for you, the needs of the patients, the healthcare needs, the needs for additional physicians, nurses, EMS resources, the needs for medications, shelter, the community needs, and then the media attention, which initially, in a chaotic disaster situation, is overwhelming. On the other end, there's all of us and all the things we use in all the places we work, the places where we can take care of patients. And the science of disaster medicine is about how to promote resiliency, promote preparedness, so that this imbalance is less imbalanced at the onset of the disaster and can be brought to a level where patients can be cared for well sooner. So much, again, of disaster response happens at the scene and is done by EMS. This talk, in large part, is about triage, the initial sorting of patients after they've begun to be cared for, and primary triage is what happens at the scene. One of the most common mass casualty events that potentially could be a disaster and overwhelm resources that happens in the United States. Kids are returning to school, traffic is increased, our roads may not be designed for the volume of travel that's on them, and school bus crashes are common no matter where in the country we are. So primary triage is the initial sorting of patients based on their injuries and based on who needs to be transported first. EMS performs that initial triage at the scene and stabilizes patients. We'll talk about different triage systems and what sort of treatment is done soon after triage in just a little bit. Then, children are transported in secondary triage, who gets the first ambulance to definitive care, so that ultimately we achieve the goal of having the best possible outcome for children. Next person showing up here is my son, Henry, who just started first grade. I love Henry dearly, and I don't go along with what his sisters say about him as far as him being a little disaster in his own right, but triage and then having a continuity that begins at the scene and ends with discharge from the hospital and rehabilitation of injuries gives us the best possible outcome for a child who's been a victim of a disaster or who's the single patient who suffered trauma or an illness. So out of all the things we could talk about disasters, we could talk about family resiliency. We could talk about family reunification. We could talk about rationing of ventilators in a pandemic flu situation. There's so many things we could talk about. One of the reasons I like to talk about triage first is triage is a bit of a microcosm for all of disaster medicine in its own right. It introduces the scope of pediatric disaster medicine or disaster medicine in general because it's different than what we do on a day-to-day basis, but its goal is to get what we're doing back to what looks like what we do on a day-to-day basis. Triage is applicable to all multiple casualty incidents. In the emergency department, if we have more than 2 or 3 critically ill patients, even if we have 2, there's a need to think about who is going to be cared for first if they arrive at the same time. In a busy pediatrics clinic, if there is a social need that needs to be addressed, triage comes into play too. Who is going to see the social worker first? So in multiple casualty events, triage really does have an impact on patient outcomes, at least as far as who gets to the hospital first, who's going to get to the OR first, et cetera. Not too many people have experience in doing triage unless they have an EMS background or a military background, and time for training is limited. So if we look at what our EMS colleagues do at the scene of a disaster, there are some commonalities no matter what type of triage system we're talking about. First, we're going to talk about what triage has in common, and then we're going to look at a variety of different triage systems used across the world, and we're going to look at the triage system that's used right here in the District of Columbia. So primary triage assigns a color-coded triage group to each of the victims. And those categories, across almost every triage system in the world, there's 4 categories. There's immediate. These are patients who are critically ill or injured, but if resources are used in a pretty immediate way, it's felt that they have a good chance of survival. Some of the things I just said are pretty vague, right? Good chance of survival, immediately, even that can be pretty vague. But given all of those things, that is the idea. A patient who gets a category yellow is somebody who's not ambulatory, but their vital signs are stable. Their mental status is okay. Someone in that category can wait, but they're going to need attention. Examples might be somebody with a fracture of their leg, or it might be an example of somebody who is really suffering some mental health consequences immediately after the disaster and won't move, but their vital signs are okay. Ambulatory, if somebody can walk after a disaster, it means a lot about them. It means that they're able to process information, they're able to listen to a request to walk toward the first rescuers who arrive. And with the exception of a few types of disasters, blasts come to mind, it probably means that they are that they can wait and that they don't need too much in the way of care right now. And then finally, there are patients who are deceased, either clearly deceased or felt to be non-recoverable. Some triage systems use an expectant category, which adds on a gray color zone where the patient is still alive but not felt to be somebody who can survive. Okay, but the deceased or non-recoverable patients will get a tag that is either black or blue in color. And once primary triage is done, there's no going back to that primary triage officer. More things are going to happen. That initial triage officer may be an EMT or a paramedic who has learned disaster triage and maybe has never done it before. We'll talk about the implications of that. We want an orderly progression through the triage system, and once everybody's triaged, they go to color-coded designated areas for their triage category. So if you find yourself in a situation where you are the first medical responder on the side of the road and there's a disaster, you're the first person who's triaging patients. If all of you were victims of a disaster, potentially somebody who was injured, if I was to say, if you can hear my voice, walk over here, I've done a lot of the sorting already, right? And if I have all of you who are uninjured walk my way, then I'm beginning to shift the balance of that teeter-totter, of that seesaw. Because in that crowd, there may be somebody who recently took a CPR course. There may be a nurse. There might be somebody who knows how to keep an airway open until more definitive help arrives. Many victims are going to be category green, and one of the problems with this is what I'm presenting to you right now is kind of an ideal situation where the patients start in one place, they go through triage by EMS, they arrive at the Emergency Department of Children's National in a way that is prescribed by EMS. We know that that doesn't happen. And the reason that doesn't happen is children who are category green may be transported by their parents to the emergency department first. There are a lot of other ways that patients may come to the emergency department other than EMS. But it is important to know that once a person shows that they can walk, they get a green tag, you're done with triage for them. As soon as you can categorize a patient as red, yellow, green, you're done. There's no need to continue through the algorithms that we're about to look at. And I promise we are going to go through some really, healthcare-looking algorithms with rectangles and hexagons. But once you reach a decision in any one of these algorithms, you are done triaging the patient. During most triage systems, there's not much in the way of treatment. There is the opening of the airway. There's the perhaps the provision of some bag valve mask ventilation, and the application of a tourniquet if somebody has active arterial bleeding. And that's about it. Treatment is very different from triage. We want to sort through patients quickly so we can decide who to treat first. On this slide, we're taking a look at not an exhaustive list, of every triage system in the United States and the world, but a reasonably thorough one. There's a system called Triage, Steve, which is used in Australia and in some European countries. We'll take a look at that one first. We're going to take a look at the START system, the simple triage and rapid treatment, and Jumpstart, which is a modification to it that was created about 20 years ago by a pediatric emergency physician named Lou Romig. That remains the most commonly used system across the country, but the tide is turning, and we will be talking about the SALT triage system, sort, assess, and life-saving treatment. We'll also take a look at the SMART system, which, a lot of these are acronyms. Colin Smart, who's British, had the audacity to name a system after himself, which, if nothing else, it makes it so someone who's getting involved in disaster medicine doesn't need to memorize another acronym. We'll look at SACO triage, which has become a bit of a historical oddity, but a good mathematical approach to triage. And then an idea that's used in Rhode Island and a few other states, which is, listen, how often does someone actually perform disaster triage? Does an algorithm actually help? And might it be better to just let paramedics and EMTs use their clinical decision about who's a red tag, a yellow tag, a green tag, et cetera? So the first of the algorithms. Steve triage, I won't talk too much about, other than to say it's pretty quick. You take a look at whether the patient's breathing or not breathing. Then you take a look at how fast they're breathing. And then you take a look at their capillary refill. So some skeptics in the audience already may be thinking, listen, if I have to triage 15 patients or 50 patients, do I really want to stare at the patient's chest and determine a respiratory rate? That takes time. And the more patients there are, the less time I have for counting out a respiratory rate. And also capillary refill for children, if they're outside, if it's cold, it may not be the best assessment for their perfusion. That's Steve triage, not widely used in the United States, but just an appetizer before we go to the main course. Next comes SACO triage. SACO triage, rather than having 4 different color-coded categories, has, with some modifications, up to 16 different categories. So if a person's a triage nurse and they get the call from the incident commander, the EMS incident commander, and they say, I have 4 number 3s, 5 number 2s, really sick number 7 that I'm a little worried about, even though they're a number 7. And that person, at the other end of the phone deals with disaster response infrequently. That sounds more like ordering off a menu. It can be pretty not intuitive. I think we can wrap our minds around red, yellow, green, black, etc. But this numeric system has not caught on, despite the fact it has some large database-driven research to support it. Here's some things that I think are good about it. It takes a look at whether the patient is breathing, looks at their respiration. It looks at their pulse, although counting these things out is a limitation. It looks at their mental status. And this looks a lot like a GCS mental score. If you look at the M that's here in the RPM score, right? And then as a pediatrician at heart, I like that there's an aging adjustment. There's a prioritization of young children and then of adolescents. People in our broad age group, my broad age group anyway, get 0 points. But then as I age, in a decade and a half or so, I may not like that there's negative points for being older and even fewer points when I reach retirement age. So anyway, the SACO triage method is based on large databases like the National Trauma Data Bank. There's good evidence to support it, but the practicality is the reason it's not what we use. What do we use? SALT triage is the product of a CDC commission that was put together in 2008. No matter what sort of physician, nurse, or other healthcare professional you are in the room, you've probably seen the phenomenon where there's good evidence to support something, there's something that has the consensus opinion of a large number of people, and it takes a decade or more for it to catch on. Here's a story that's like that one. So SALT triage is now the triage system that is recommended by the National Disaster Life Support Foundation. This foundation does courses called Basic and Advanced Disaster Life Support, and it takes a look at first whether a patient can move or not, Then it takes a look at whether how severe the patient's injury is. Then there are life-saving interventions. This is the application of a tourniquet, this is the opening of an airway. This is giving 2 rescue breaths to children. There's no science behind that. There's no study that's been shown that children in disaster situations who are apneic are more likely to survive if they receive 2 or 5 rescue breaths. It's just what the consensus panel said. And then finally, there's treatment and transport of patients. Here's a bit of an algorithm that depicts SALT on one slide. I'm going to draw your attention to this, which is the one modification for children. If you're a child who's apneic, fit certain criteria, you get 2 rescue breaths. Other than that, children are treated just like adults. In the questions section, we can talk about that. Here's a picture of a friend and colleague, Brooke Lerner, who's a PhD and also has a history of being an EMS provider who does a lot of triage and disaster response research. She was part of the panel in 2008, and she has persistently advocated for SALT for the last decade. And now, as of this year, the District of Columbia and some of the adjacent states, at least Maryland, are using SALT triage. This is one of those nightmare algorithms from the back of the room that has hexagons and rectangles. This is also Jumpstart triage. We're going to dissect this. The reason I'm mentioning this one is it is still the most commonly used system used in the United States. You're already seeing a lot of similarities across these things. The first thing that Jumpstart looks at is whether the patient can walk. If they can walk, they get a green tag and they're done. Then we take a look at whether they're breathing, there's airway reposition, there's 5 rescue breaths. Again, no evidence behind that. And if the patient begins to breathe and they weren't breathing before, they get a red tag. If they're still not breathing, they're considered deceased. We then go on to take a look at how fast or how slow they're breathing. Again, less than 15 or more than 45 breaths per minute. If you have 15 or 50 or more patients to triage, counting out all those respiratory rates can make a difference as far as the outcomes of the whole population of patients. It takes a while to do that. Then we look at whether the patient has a palpable pulse. We don't look at capillary refill. We say, do they have a palpable pulse? And then we look at their mental status. So there's an orderly progression through all of that. Another type of triage I'll mention very briefly is what we use in Connecticut, which is smart triage. It's essentially what we just looked at with the addition of a length-based tape. So what's the evidence for these various disaster systems? Using simulation, the PRIDE Research Network compared clinical decision-making, no algorithm, to Jumpstart triage, that one that we just dissected a bit, to the use of smart triage with the use of a length-based tape. This study, which was conducted in 3 sites and had paramedics and EMTs as the participants, or 273 participants, basically it showed that the addition of a length-based tape for triage was associated with less accurate triage, and or at least a system with a length-based tape was associated with less accurate triage. And it showed that the use of the Jumpstart algorithm had more accurate triage. We talk about what accuracy and triage is in the questions if you're interested, was more accurate than not using any triage system at all. Next, Keith Cross, another colleague, had the idea of applying large database research and big data from the National Trauma Data Bank and abstracting from singleton traumas. We're talking about the child who gets transported by EMS for a bike crash, the child who's the victim of violence, singleton traumas, and abstracting based on their injury severity scores what triage level they should be. And we compared 6 different triage systems. We found that SACO triage, that numeric one, it predicts outcomes better than the others. But being on the receiving end of you have several patients who are number 5s, number 3s, number 2s is far less intuitive than the color-coded triage system. Other researchers, including that panel conducted by the CDC about a decade ago, came up with some core criteria for disaster triage. It said that disaster triage should include some life-saving intervention, that it should be easily learned, that it should be applicable to any kind of disaster, and the like. So this is the landmark that was the underpinnings for SALT triage. And some members of that group recently took a look at mass casualty triage systems. I know that the vast majority of people in this room work in a hospital rather than being EMS providers. And the question that folks who work in a hospital often ask about disaster triage is, could we use SALT triage if we have a large number of disaster victims who come to the ED? This recent paper written by Brooke Lerner and one of her colleagues suggests that actually know that pre-hospital triage systems don't really work well in the ED setting. And we can think about why that is, most likely because in a hospital, the resources are quite different than they are on the side of the road. And there's already been some selection of patients who are likely to survive. If the patients who make it to the hospital, again, are more likely to survive. All right, so here are the gaps in triage science. If you are a young researcher or a not so young researcher who's interested in disaster medicine, real world performance of disaster triage systems is something we really need. We need to take away simulation as a proxy. We need to go away from abstracting from singleton trauma data banks, even though we can get large numbers that way. And the reason we haven't done this already is pretty difficult to have a pre-existing IRB that's ready to go in the Bahamas or in downtown New Haven when a disaster occurs. We also don't know, we teach things a certain way, but how do providers actually apply the triage system? Are they doing it, does it turn out that they're just kind of doing what their gut tells them, and it's just loosely based on the system? And then what are the long-term outcomes? If we use a triage system, does it really impact long-term survival? So much of what we care about in healthcare now, right, is about linking to real patient outcomes. And what's the effect on providers? What are the long-term mental health effects of being the person who's had to apply a black tag to someone? So if we think about EMS, pediatric disaster education, or disaster education in general, there are so many things we can teach. I've emphasized triage on this, but first there's the initial scene management, there's ensuring that the people who are responding aren't going to become ill or injured themselves, issues of decontamination and family reunification and transport. For every child who is involved in a disaster, there are, you name it, how many parents, grandparents, siblings, people who care about that child who are directly impacted because that child is involved. There are alternate care sites. If we just look around the medical campus here and we think about what's going to happen if the emergency department is overwhelmed, where is the next ring of clinical care sites when the next pandemic flu happens, or if there's a chemical attack at a schoolyard in DC. So where are the alternate care sites, and how does the hospital interact with public health, with EMS, with police and other authorities, and the like? So there's so many challenges to healthcare education in general, right? We're sitting in this auditorium in September of 2019. The disaster that you all may respond to may not happen until 2024. How do we remember what happened during a lecture in September of 2019? So there's this idea of initial training and then continuing education or just-in-time training that can occur. The dyssynchrony is what I just mentioned. It's an uncommon patient group for EMS providers. Children represent less than 10% of all patients who are cared for in an EMS setting. And then these events, I have the word rare here. Maybe I should use the word uncommon. Disasters are uncommon, and getting good at doing disaster care through education is difficult because this topic competes with all other topics that our learners are expected to take on during residency and during medical school, and that all of us who do continuing education are expected to learn as we continue through our careers. So there's a decay in knowledge and skill and in self-efficacy. I always feel like I am at my best when it comes to airway management intubation right after I've spent half a day in the simulation lab. Oh, yeah, I can do that. And then when the child comes in a couple months later, I think, all right, it's really time to curl my toes and be sure I know what I'm doing. So this is the part that I mentioned for educators, right? And this doesn't necessarily need to be something about disasters. It's just a few slides about curriculum development. And basically, the take-home from this is everything should be driven by the needs of the learners. First, we do a general needs assessment. Workers in a children's hospital in the United States, in general, will benefit from knowing these things. And what's the ideal approach? Next, we look at the needs assessment for a targeted group of learners. So for everyone who's here, if we think about a hazard vulnerability analysis, as far as I know, there's no fault lines here in DC, so an earthquake isn't a likely event. But we are pretty close to the sea, and hurricanes are a real concern. Everywhere in the United States, there's a need to talk about gun violence and mass shooting. So what are the needs as far as learning about triage and about the management of these kinds of situations for a population of learners, let's say in DC? Based on those needs, we write our goals and objectives. The goals, of course, being overarching statements of what we're trying to achieve, and then the objectives being things that we can measure. We look at educational strategies. What we're doing right now is a didactic. It's great for bringing a large number of people into one place at one time. This is synchronous learning, right? So far, since Joelle introduced me, I'm the only one who said anything. There hasn't been a lot of flow of information, and as you guys know, this is the least. This is the way that information is least likely to stick. There's some dysynchronous learning going on, and this is being recorded, or asynchronous learning, so somebody could pick this up off the shelf months from now. And of course, people are learning remotely right now. We look at experiential education like simulation, tabletop exercises, video games. These are some ways to better hone skills and knowledge, cognitive skills. Then we implement our curriculum, and then we do evaluation and feedback. Not just evaluation of the learners, but evaluation of the curriculum. It's this model, the Kern method for those previous 6 steps, and then the Kirkpatrick hierarchy, which is a way of looking at the impact of how we teach on how healthcare is done and ultimately on patients. So at the very tip of this illegible pyramid, it says benefit, ultimately the quality of clinical care and patient outcomes. It is the most difficult outcome to track back to medical education, and it's the most important one. At the base of the pyramid is, did the learners like it? Was Cicero a tolerable grand round speaker? I hope so. But then more important than that is, did the talk give some new perceptions and some new attitudes about disaster readiness? Did people acquire new knowledge and skills? Were there changes in behavior? And then finally, changes in organizational practice. If we achieve these goals, then our curriculum is worthy. So a lot of what our group, what Pride has done, has been around live simulations. There's a lot of advantages to it. Other than actually responding to a disaster, there's nothing more realistic than a simulated multiple mode disaster simulation that has actors like the one you see in the slide, cradling a high fidelity baby. It allows for hands-on skill practice. It allows for debriefing in real time. Simulation experts like to say, the reason we do simulation is so we can debrief. Simulation helps us uncover differences between actual practice and where we want to be. There are limitations to this. And then, in the interest of time, I'm not going to go through our consort diagrams or what we did too much, other than to say we used live simulations for paramedics and EMTs to help them hone their triage skills. We found that if I orient you to the y-axis there's the median score. This is actually percent accuracy in triage. There's a baseline score, and as we march across the x-axis, we've got their improvement at 2 weeks and then 6 months using simulation as the intervention. We found a pretty high baseline level of accuracy for paramedics. They were right about 80% of the time. And after a simulation intervention, they were more likely to, they triaged 1 additional patient out of 10 properly. And more important, for an educational intervention is we were able to see that 6 months later with no additional training, they maintained that ability. It's great. but it's also pretty costly and requires a big commitment of time on the part of the learner. So the next thing we looked at is how can we take the learning out of the simulation lab and put it in people's pockets and on their phone. So video games in medical education have been around for 20, 25 years, maybe longer. The first references in PubMed go back to the mid-90s. So whether it is physician trauma triage and looking at how physicians use video games to learn triage, or whether it's looking at decision-making around transfers, where a video game improved behaviors around patient transfers, we saw that there was already a burgeoning kind of bank of information about how video games can be learned. And then it can be used to help people learn in healthcare. If we think about the average EMS provider, more and more that person is a woman, but the average EMS provider is a guy. He's in his 20s or 30s. He's played a lot of video games in his life, and he has a smartphone. If we can compete with social media, sleep, being sure that someone's ready for their 3 a.m. call, this is a way to disperse the learning to the learner where the learner is. So we created a video game called 60 Seconds to Survival. I encourage you, if you're an EMS educator, if you're somebody who's interested in learning more about disaster triage, this game is free and readily available. The website's coming up on the conclusion slide. And it's a way that we were able to take 3 fairly common across the United States types of disasters or mass casualty events, school shootings, house fires, and tornadoes, and help learners learn about doing triage. We had an emphasis on children with special health care needs, and at that time, START and Jumpstart still had their stranglehold on being the primary triage systems used in the United States. Still the case now, although that's eroding, probably for the best. There are some advantages of video game education. We can represent victims with the game. We can take it to the learner, and there's no need to use actors or mannequins. Again, this allows for asynchronous learning. It allows for the learner to approach the information when they have the time. There's no need for facilitators or instructors, and there's immediate feedback. There's some real limitations, however. If a live simulation gets us kind of close, a video game gets us pretty far from being a responder to an actual disaster. And once the video game is up and running, there's some costs associated with modifying it. But we can reach thousands or tens of thousands of people with a video game rather than dozens or hundreds with a simulation at a simulation center. The consort statement for a single site randomized controlled trial was on the previous slide. I just put this up here to say that as far as improvement in triage accuracy decisions, this slide looks very similar to the improvement that we had when learners went through a live simulation. So we were able to achieve similar level of improvement in triage decisions with the same population, or at least similar paramedics and EMTs, with video games as using live simulation. All right, so how do we further incorporate disasters into training, particularly around children? This is a center that is relatively prepared for disasters because of the commitment and because of the personnel who are here. But we are all potentially able to benefit from doing a hazard vulnerability analysis, looking at the various educational interventions that can be done for all of our learners, including practicing physicians, and doing evaluation. Looking at the pediatric needs and pediatric disaster readiness, there is a place for live simulation, and there's a place for all the other modes of learning that have been described here so far. Think about the scale that you need, whether it's the readiness for the ENT clinic for a disaster, or if it's a need for the entire health system and the interface between Children's National and the VA, or Children's National and the 6 closest children's hospitals to this spot. And the needs will help guide your goals, objectives, and the sort of educational intervention you use to achieve those goals. And you want to keep the goal the goal. This is important in disaster medicine, it's important in research, and it's important in life. Hold on to what the goal is. That drives everything else, and then that will help you do your evaluation and then make some new goals to continue to improve. All right, a bit about children and a bit about family disasters, and we'll draw this to a close. Things are more complicated when there's a family. There's more vulnerability when there's a family. And when there's a child who's being triaged, you know, if I said to a room full of toddlers, if you can hear my voice, walk over here, far fewer of them are going to walk toward me than adults. Injured kids may be extricated by their parents or adults, as we talked about before, and that may kind of stymie the triage system. And children, once they're triaged, tend to not stay put. If we can keep the family together, we are doing ourselves a favor, we're doing the parents a favor, and we're doing the child a favor. If there's a parent there who knows that child is allergic to medication, it's a lot better to have that person with them than to separate them and send them to different hospitals to be treated. And this is something that I'll leave to the local disaster planners, how you're going to manage that. But it does increase everyone's anxiety, including the EMS providers, when we separate parents from their children. Everything we talked about with triage still applies to kids. Some things that are particular to them is apneic kids are more likely to be apneic for primary respiratory reasons than for cardiac reasons. There are developmental considerations. There are all the various inborn errors and malformations and the things that pediatric providers and specialists know about that an EMS provider may have a difficult time recalling. The goal is to triage patients in less than 30 seconds. So in the face of all of this, the event, the children, and all that's going on, there's a need to triage quickly so that everything else in disaster management can be addressed. Finally, if we're going to incorporate pediatric disaster simulation, video games into EMS education, and into hospital worker education, we need to think about how often we do the education. When the initial learning happens, there's no better time than Preparedness Month to begin to think about these events and how we all respond together, but then a need for re-inoculation and just-in-time training. I'm currently very fortunate. I'm on sabbatical, and I had a chance to go to Israel. People have been telling me since I was a fellow and became interested in pediatric disaster readiness, go to Israel, we'll see how disaster preparedness is done on a world-class level. And if we make it so that disaster preparedness and making sure that roles in a hospital during a disaster are as ingrained as who stands at the head of the bed in a resuscitation, who stands at the foot of the bed, who does chest compressions, I don't think we'll do a worse job at disaster preparedness. The question really is how we get from where we are now and assess where we are now to the best possible response before the patient arrives at the hospital, in the hospital, and afterward. So in conclusion, here are some ways to do it. If we do triage Tuesdays, such that every time a patient comes into the emergency department, the EMS provider and the nurses make a decision about what the disaster triage level would be for the patient. That's the way to do it. Incident command system mini drills. If you're an administrator in the Children's National Medical Center, thinking about not necessarily the clinical end of things, but how will we close down elective surgeries? How will we make more clinical space available? What's the communication system? How do we make all of this come to bear? Thinking about it now when it's in the abstract rather than in the moment when it's necessary is helpful. And then working with all sorts of community groups where children gather to improve preparedness. In really real conclusion, there's no evidence to support, or there's no evidence that comes directly from disasters to support the use of any one disaster triage system. The SALT triage system, recently adopted by the District of Columbia, has the backing of the CDC, has the backing of national experts, and has a growing base of information that's indirect that supports its use. So there are some gaps. People will be studying triage for the rest of my career, I expect, beyond. More importantly, for a healthcare system, there are educational methods that can be used to improve disaster readiness, to improve people's self-efficacy, to improve their practice, and we think to improve patient outcomes. We need to prove it. We need to improve it and make it better. And as a shameless plug, if you're interested in the use of the disaster triage game, the website is here. Thank you so much for having me. As the audience, as I've looked out at your faces, I see that there is a pretty strong connection between Yale School of Medicine, Department of Pediatrics, and some of the faces in the audience. And it's good to see a good number of colleagues out in the audience as well. I really appreciate your attention, and I'm open to questions. Thank you. Dr. Teach. Here comes the mic.
Stephen Teach from the Division of Emergency Medicine. Mark, that was really outstanding and just a great summary of sort of the state of this field. I have a kind of a question that's a little bit tangential, but I think really important in this field. Children's National has long had a focus in its research and advocacy on disparities in healthcare and health outcomes. Is there any evidence that in the disaster preparedness world and triage world that there's systematic or potential for real-time disparities? And I'll ask you to answer the question on two levels. One is at the systems level. Is there evidence that urban disadvantaged communities are disadvantaged with respect to access to EMS and triage and disaster preparedness would be one level. The more interesting level, though, is at the individual level. Is there any data, any science that looks at ageism in triage, genderism in triage, racism in triage, any of the differences that distinguish us, and do they affect real-time decisions in the field by frontline providers?
Sure. So the systems level question, as far as disparities in triage, is the relatively easier one to answer for the guy up on the podium. We don't need to look too much further than, say, Hurricane Katrina or the events in the Hurricane Superstorm Sandy in greater metropolitan New York City to see that children who lived in relatively impoverished zip codes during those two events had longer response times from EMS, tended to have more separation from their families and longer duration between reunification from the time of the storm, and that responses from EMS to go to, say, the lower Ninth Ward during Katrina were longer. Now, of course, there's geographic variations, elevation pieces that can go with that too, but it seems like children who live, or just people who live in impoverished areas, tend to have longer response times from EMS and to fare worse in disaster situations. What's interesting is thinking about the individual, racism, ageism. I showed you SACO Triage, which has built-in ageism, ageism toward, bias toward the care of children and away from the care of older patients. And, as far as emergency department triage, singleton triage, as far as evidence for racism, gender bias, these sorts of things for disaster triage, I have not seen any data along those lines. But what I can say is that in general emergency departments, if we think about gender biases regarding chest pain, or if we think about how pain is managed based on a person's race, and we've all seen issues around how, say, sickle cell pain is managed compared to other types of pain, or where race has been, after we look at a multivariate analysis and take out a whole bunch of other patient-specific variables, if we look at race and look at how well pain is managed when there's, say, a fracture, that is persistent. So although I don't know of any data that say that a child with one color skin is going to be triaged with less priority than a child with another color skin in a disaster, I fear that that is another issue that comes to play and can further make children vulnerable to having poor outcomes in a disaster. We have a question up there.
Hi, I'm Adelaide Robb, the head of the Psychiatry Division. One of the things we know from other disasters with kids is that if people are around adults who are remaining calm, they're warm, they're dry, they're in a well-lit area, the incidence of PTSD is less. Do you think any of the different triaging systems you discussed take into account making sure that we do as much as possible to minimize PTSD in kids in the event of a disaster?
Right. So the primary triage systems, by design, do very little to think about minimizing PTSD. But good pre-hospital disaster response now integrates issues and skills in mental health first aid. The recognition that a responder's presence and the way the responder is reacting to children makes a difference, either for good or for ill. And, in the initial scene management, keeping families together, being reassuring, being truthful, having means to keep children warm, not taking people's clothes off when there's a need for decontamination and the like. There is a recognition of the long-term mental health consequences, even of that initial scene response. So the primary triage, by definition, needs to be quick, needs to be 30 seconds. Our EMS providers are receiving education about mental health first aid, family unification, and keeping families together, as well as the mental health needs of children, specifically during disasters.